Good evening, everybody, and welcome to this event sponsored by Flen Health and assisted by Mould Digital. My name's Leanne Atkin. I'm a vascular nurse consultant at Mid York's NHS Trust, along with a researcher at the University of Huddersfield. And it's my delight to be here on this webinar today, talking about managing wounds at risk of infection, especially those in difficult to dress areas. And I'm delighted to be joined this evening by Professor Steve Percival, who is the professor at the School of Medicine within the University of Manchester. Good evening, Steve.
Good evening. How are you?
I'm good, thank you. I'm good.
Beautiful.
So we're going to do a bit of a double act tonight. Steve's going to give you a bit of information relating to why antimicrobial stewardship is important, especially in relation to wound care. And then I'm going to, after Steve, provide you some information in terms of how do we go about managing wounds in those difficult to redress areas. And why is the use of Flaminol relatively a versatile product in that space? So Steve, over to you.
Lovely. Thank you very much. Good evening, or good afternoon, good morning. Thank you very much for joining me today. Today, I'm going to give you a quick overview, a brief outline of antimicrobial resistance and why it is important. We have to take into account this term antimicrobial resistance because we also have a term antibiotic resistance. So the word antimicrobial doesn't just cover antibiotics, it also covers other antimicrobials that are used in many different professions. What I aim to do today, first of all, is give you an overview of what resistance is, how bugs acquire resistance, or if it's inherent in these bugs, discuss the concept of biofilms, and also have a bit of a discussion on cross-resistance of antimicrobials to antibiotic resistance. So first of all, the big question is, what are antimicrobials? So antimicrobials can include anything such as antibiotics, antivirals, antifungals, antiparasitic agents. And these are medicines which are used to both prevent and treat infections in both humans and animals, and also in plants that often we forget about. So antimicrobials are generally put under a big term called biocides. So biocides cover anything that may be used to actually kill, prevent the growth, or inhibit anything that's growing that may be an issue. So things like pests. So biocides can include pesticides. So these are used a lot on plants as well as in soils. And they kill all microbial forms of life. When we then look at antibiotics, now antibiotics have evolved from fungi in particular within the soil. So bacteria have always been exposed to antibiotics. So they've naturally acquired or selectively developed some resistance to antibiotics. So antibiotics are often like sniper's bullets. So they're very, very specific by which they kill bacteria. What we do know as well is with antibiotics, they can be very toxic. So as well as killing bacteria, they can also be very toxic to normal human cells. So there has to be a fine balance as to how long we use antibiotics and what concentrations they're used at. And in particular, if you take them orally, we know they can cause gastrointestinal problems. So often it's advisable to have probiotics in addition to antibiotics to help keep your natural bugs in balance. We know these antibiotics are often very selective and resistance is very common. And this resistance can be inherent. So those bacteria have resistant genes already, or they've acquired resistance. And they often acquire resistance in communities, which is a fantastic area, which we'll discuss in a minute, called biofilmology, whereby bacteria can acquire a lot of these genes in things called plasmids, where one bacteria passes on genes to another. The other area of biocides where we control microorganisms is an area called where we incorporate many, many different agents that are used on hard surfaces. So these are generally called disinfectants. These are often non-selective. And what I mean by that, they'll kill bacteria, they'll kill viruses, and they'll kill fungi. So things like chlorine that most people use in their kitchens is generally referred to as bleach. And this has a very, very high level of chlorine, at roughly 1,000 part per million. We have other things such as PHMBs that were actually being used as disinfectants in swimming pools and are often used to clean beer bottles. And we have other ones such as peracetic acid that's often used, particularly in industrial water lines, that replace things like glutaraldehyde. So disinfectants are used on non-living objects because they're at very high concentrations and would be very detrimental to cells, of course. So, of course, antiseptics then came along, whereby these agents can be used on living actual tissue. They've often evolved from disinfectants, but they're used at significantly lower concentrations. So we know things like hypochlorites are used at low concentrations when they're actually making contact with the skin. And it's the same with PHMBs. So just like disinfectants, antiseptics have a broad spectrum of activity. Resistance is rare, but has been reported. For example, these silver-resistant genes have been found. Often they're found in Enterobacter cloacae, so it's an inherent gene there that these bacteria seem to have. But there's a growing concern now with the use of antiseptics and their crossed resistance to antibiotic-resistant genes, which we'll discuss very shortly, which is a reason why the FDA are banning some of these antiseptics, of course, because they're being used to preserve a lot of cosmetics and they're causing some issues, of course. When we think about antiseptics, these are chemically sterilizing substances. Antibiotics, of course, can be synthetic, semi-synthetic, but they're generally from a natural source, so they've been found within the soil. Antiseptics aren't the same. These are chemicals, and they can either be used to kill bugs, so they're microbiocidal when they kill the bacteria, or they can be microbiostatic when they just stop the bacteria actually growing. We know there's many modes of action, and that's very good from a resistance perspective, because if we apply an antiseptic and a bacteria develops some tolerance or resistance to that antiseptic can kill that bacteria in a different way. So, for example, some work on the cell wall to break it down, some work on breaking down DNA. So what will happen is that that antiseptic will have the ability to kill that bacteria or microorganism in different ways. So resistance would be significantly lower than you would find with antibiotics. We know they have a broad spectrum of activity, so they kill a whole array of different bacteria, gram-positive, gram-negative, anaerobes, microaerophilic bugs, fungi, yeast. Now, toxicity, as well as with antiseptics, does generally exist because it will do, because if you're killing bacteria, killing microorganisms, you're going to need a certain concentration that will also have an effect on cells. But we have to get the balance right with antiseptics, and it's often called the biocompatibility index, where we can look at the balance between cytotoxicity and antimicrobial efficacy. So lots of these antiseptics have this index so you can determine which one is less detrimental. But when we have biofilms, of course, which are often recalcitrant to a lot of antimicrobes, antiseptics, we have to use higher levels of antimicrobials to actually kill the bugs. So what is antimicrobial resistance? So it can occur in bacteria, viruses, fungi, as well as parasites. And this is where the microorganisms do not get affected by the use of the actual antimicrobial. So what happens is it becomes harder to kill those particular microorganisms. And as a result, of course, we're getting problems in terms of treating many diseases and infections that have these microorganisms that are both more tolerant as well as resistant to antimicrobials. And as we're treading on thin ice here, we're finding that there's a lot of work taking place that's telling us now, in due course, a lot of these antimicrobials we utilize are becoming ineffective. So vancomycin, as we know, the first vancomycin-resistant Staphylococcus aureus was discovered in 2001. And we know there's quite a prevalence of those particular resistant bugs that are evolving around the world. So what are the main drivers then of antimicrobial resistance? Well, the first one, as we're practicing antimicrobial stewardship, it's all about education. It's all about understanding why we use antibiotics, when we use antibiotics, and ultimately not overusing and misusing antimicrobials, because not every single condition requires an antimicrobial, of course. Also, you've got to think from a global perspective, access to clean water is a problem. Communicable diseases, passing on microbes from one person to another is a problem. So the dirtier we become, of course, there's a higher risk of us spreading these antibiotic resistant bugs, but there's also a thing called the hygiene hypothesis, where a lot of people like being dirty and eating soil because it's often a way of exercising your immune system to keep it up to a good level whereby we kill microbes. But what often happens in a few parts of the world is we get a lot of antibiotic resistant isolates in drinking water as well as in wastewater. So it gets into the whole water cycle and passes around different communities. Also, when we're dealing with infection and disease prevention, a lot of antimicrobes are used in farms, on animals, so these can often be used indiscriminately. And of course, a lot of animals can disseminate a lot of these antibiotic resistant isolates. So as we know, we have to be careful of zoonotic infections. So these are infections whereby you've got a microorganism from an animal and it passes on to a human and causes a disease or infection. Also, access to affordable medicines and vaccines has led to a main drive of antimicrobial resistance, and also a poor awareness and knowledge as to why we're using antibiotics, for example, and the appropriate use of them. So, for example, many years ago, particularly in the oil industry, there's always a problem with biofilms on oil pipeline systems, particularly in areas such as Canada. So what they used to do is put antibiotics actually into the oil pipeline systems to try and get rid of biofilms. So ultimately, this pressure of an antibiotic will start selecting for those bugs that have inherent resistance. So these will become a predominant population that could withstand antimicrobials, of course, down the line. So as it's a growing public health challenge, it's been recognized now as one of the top 10 threats to global health, and it's increasing constantly. And what we're finding that potentially in the next 20 years, many of the current antibiotics we have will be ineffective. And this, of course, leads to major problems. And we're looking for different ways of enhancing antimicrobials. So there's a lot of work that takes place in terms of utilizing permeating, sensitizing agents that can actually make the bacteria more susceptible to antibiotics. So things like EDTA, DTPA, these can alter the cell wall of bacteria to allow antibiotics to get in more effectively. So these sorts of bits of research are taking place around the world. But it's estimated that at least 10 million people will die from antibiotic related infections and diseases, and the cost to the global economy, as you can see there, is huge. So of course it's a growing concern we have to try and get hold of as more and more infections and diseases are becoming more epidemic and pandemic, even though there's essentially an endemic going on with a lot of diseases out there. So, as I said, when resistance becomes a concern, this can lead on to things such as failures in treatment for patients, it increased mortality rates, the spread can increase in terms of the community. And we've got to be careful as well when there's bed changes. One patient goes onto a bed that's had a patient prior to them with an antibiotic resistant isolate, because transmission of antibiotic resistant bugs is quite high in those situations. There's a constant low level of resistance. As I said, there's an endemic level of resistance always in the environment, of course. And we always have to, as I said, bear in mind that, for example, dogs and cats can carry MRSA. And even the human population, 10% of us will always carry MRSA, which will cause us no problem unless that MRSA moves from where it is to a place where it shouldn't be. So, for example, in a wound is where you don't want to get MRSA. There's increasing costs, of course, to the healthcare profession, whereby if there are issues with antibiotic resistant isolates, and if we constantly indiscriminately use antimicrobials, this is an ongoing selective pressure to actually select for those bugs that have enhanced tolerance and resistance to antimicrobials and antibiotics. So when we use antimicrobials, education is very important, and you've got to understand how we use these antimicrobials, because of course a lot of them at low levels are not very effective when there's a lot of biological material around, when it's dirty in an environment, because these materials always have a demand for antimicrobials. And this is an example that was done at Montana State University many, many years ago. And what this is showing you is that when we treat things on surfaces, we have to make sure we maintain and sustain high enough therapeutic levels of an antimicrobial to reduce those bugs to an acceptable level. So what you can see here, this is the use of chlorine here, for example. Bugs that are living are red, so they're respiring. Bugs that are dead actually go a nice green color. And what this is showing you over time, when you apply an antimicrobial on a biofilm, what you start doing is killing the bugs on the surface first. And these are always the most active of the microorganisms on a biofilm, the ones at the surface. As you move deeper into the biofilm, this is where the bugs are more dormant and quiet and are harder to kill. And as you can see here over time, and this is quite a long period of time, it takes a long while until that chlorine starts penetrating down into that biofilm to kill the microorganisms that are found near the surface itself. But it's important to bear in mind you will not kill all microorganisms. No environment will be sterile unless, of course, you've sterilized it with gamma radiation or autoclaved, for example, at certain concentrations, but then prions come into play there. So we have to be mindful of that. But there's always 10% of a bacterial population that you can't kill, be it in the planktonic state, which is a swimming state, or the actual attached state. And these cells are often called persister cells, and they lack the ability to die, but we'll touch on that very shortly. So in terms of mechanisms of action, in terms of bacteria, for example, bacteria either are born essentially or have inherent genes that give them the resistance to antimicrobials, in particular antibiotics, or bacteria can acquire genes that have resistance to antimicrobials or antibiotics. And one area, as I mentioned before, where bacteria can acquire genes is within a biofilm. And genes can be passed on from one bacteria to another via a process whereby plasmids, which are extracellular to the DNA in the actual nucleus of a bacteria, they can be transmitted by a thing called a pili from one bacteria to another. So it's like a little tube that will go from one bacteria and it attaches onto another bacteria and can shoot its plasmid into that bacteria, and then that bacteria then acquires that resistant genes. And as I said, that happens often within a biofilm. So resistance may develop, for example, because a bug lacks a target for a particular antimicrobial. Some bacteria have the ability to pump things out. So it can take the antimicrobial inside itself, but it then pumps it out again. So that antimicrobial will never get to a concentration to kill that bacteria. Some bacteria can produce extracellular enzymes. So penicillinase has the ability to break down penicillin. It's been found in a lot of bacteria. So these enzymes that bugs produce come from the genes that may be inherent or may be acquired when the bugs have been growing in the biofilm. So here's a little example here showing you all the different mechanisms, and there's quite a lot. And you have to bear in mind these are gene-specific mechanisms, so limiting the uptake of a drug, modifying the drug. So some bugs can produce chemicals to alter the activity of that drug or antimicrobial, inactivating it, and or as I said, pumping it out. That, whilst involves genes, we have to not forget about the word tolerance that comes into play here, because some microbes can actually have an enhanced tolerance to different antimicrobials. So they can get a thicker cell wall, for example. If the bug becomes stressed, it produces more polysaccharides that can often soak up those antimicrobials, so they become inactive. So there's many different mechanisms by which bacteria acquire resistance. So when we move on to a wound, again, we have to bear in mind the limitations of antimicrobials. That, as I said, the dirtier things are, the less effective that antimicrobial will be. So on a wound, for example, if you've got a lot of necrotic tissue and slough, we know that these will actually soak up a lot of antimicrobials. And it's called a biological demand for that antimicrobials. So you're going to have to add a lot of antimicrobial onto that wound if they're dirty. So it's always advisable to clean the wound as effectively as possible. And this is a very important area, particularly when we're dealing with biofilms. So most of the antimicrobials developed out there, actually and tested, particularly on wound dressings, have generally been tested on planktonic or swimming microorganisms, of course. But we do know that bugs exist in two states. They exist in this swimming state, but they also are found attached onto surfaces. So when we apply a topical antimicrobial that was designed to kill bugs swimming, of course, and we've got all this necrotic tissue in slough, what will happen is you'll kill quite a lot of the microbes, but of course, we now know that there's biofilms inside slough. So slough protects a lot of those bugs from the antimicrobials, as does bugs growing within a biofilm. So when they're attached or sessile, what we know is these bugs can be up to 1,000 times more tolerant to antimicrobials, not resistant. So it doesn't involve genes, it involves tolerance only. And these bugs that can attach onto a wound bed, onto necrotic tissue, onto slough, onto a wound dressing. It can also become quite invasive. And this is a dynamic system in a wound. Whilst we've got to kill the planktonic bugs, we've also got to kill the bugs in a biofilm. So often when it's a general infection, systemic antibiotics are very important. But we have to bear in mind with diabetic foot ulcers that maybe ischemic, those antibiotics won't get to the site where the biofilm is or where the planktonic bugs are, of course. And we've got to bear in mind these invasive microorganisms, such as Candida albicans, can increase propensity to getting sepsis, and then that causes major problems. So we have to bear in mind we need to remove these barriers to healing, remove these barriers that prevent effective efficacy of antimicrobials. So then, many years ago, the concept of biofilms was put into wound care, and the first actual study that took place was in 2008 by Garth James from Montana State University that found a lot of biofilms in wounds, which is not a new phenomenon. If you rub your tongue along your teeth, that's a biofilm. And we've been dealing with biofilms for a long time. It's only in the last probably 15, 20 years that it's entered the medical profession that they realized we're dealing with different situations here when it involves chronic infections and diseases. And a good example is when you have a bath tonight or tomorrow, when you drain the water, run your finger around the outside of the bath and it'll be very slimy. And that's a biofilm in your bath water. Or leave a glass of water by the side of the bed tonight, pour the water away in the morning, and then rub your finger along the inside of a glass, and you'll see it's all slimy. And that's your best example of a biofilm. And it's not a new phenomena. It's a natural process by which microorganisms go along. So generally, a biofilm is microorganisms attached onto something. It can either be themselves, onto other microbes. It does not have to be a solid surface. It can be between a liquid and a gas. It can be between two liquids, or it could be between two gases. And it's just a community of microbes that encase themselves in extracellular material. And again, it's just not polysaccharides. There's so many publications out there just saying it's polysaccharides, and it's not. You have a whole array of nucleic acids, proteins, metal ions are in there that keep the structure together. And the extracellular matrix can make up over 80% of that biofilm. So you're just not dealing with killing the microbes. It's important that you actually remove or destroy the house of the biofilm that keeps the microbes in there. And once they're in this state, they're very recalcitrant towards the immune system as well as any antimicrobial interventions. So what we have to bear in mind when we get a lot of chronic conditions, the reason for a lot of these prolonged chronic conditions is we have a lot of cells that are tolerant to antimicrobials, and these are called persister cells. So as you can see in this diagram here, if we look at numbers of bugs and we apply an antimicrobial, what will happen is it will kill a large number of those bugs, but you're always going to have persister cells. You're always going to have a percentage of cells that are going to remain viable. And what will happen is when you remove that antimicrobial, if it hasn't been used long enough and at the correct therapeutic levels, those bugs regrow. So for example, things like tonsillitis, if you don't use antibiotics long enough, what will happen? It will come back. So you have to prolong the actual use of antibiotics, particularly with tonsillitis, because it's a biofilm related infection. And what will happen is you'll get regrowth if you stop using those antimicrobials because you think that infection is gone away. So what'll happen, you use an antimicrobial again, take the numbers of bugs down, but of course, what will happen is there'll always be a percentage of cells that you're selecting for that persist and carry on growing. So the next generation of antimicrobials need to look at that population of microbes that are very difficult to kill and often are responsible for a lot of chronic conditions that happen within the human body. So methods to produce or reduce our antimicrobial resistance. The first thing with any disease, any infection, is prevention. Once bugs get in there, it becomes very hard to get them out and kill them because, of course, it becomes biological warfare. They like the environment they are inhabiting, but your body probably doesn't like where they are. We have to improve antibiotics and antifungals, which can actually reduce the resistance developing, but resistance can happen quite quickly. So if you think about every 10 to the 6th division of bacteria, so bacteria will generally multiply every 15 to 20 minutes. Once it's divided 6 times, you will get one mutation. If that mutation is advantageous to that microbial population, you will start selecting for those tolerant microbes. We also have to think about the diagnosis and management of biofilms, because of course, not all biofilms are bad, of course. So if you think about your gastrointestinal tract, that's a biofilm. The minute you have generally most of the time we'll have healthy guts. The minute you use antibiotic, you disrupt that whole biofilm in your gut and you'll get diarrhea. So this is why you should always have probiotics with antibiotics, because you're replacing your good bacteria. And we have a thing called colonization resistance on the skin. So your skin is covered in a biofilm and it prevents a lot of opportunistic pathogens causing you problems. When you alter this thing called the microbiome on your skin, you'll get things like psoriasis, eczema, and dermatitis because you're altering the microbiology. And we've got to try and start intervening in terms of reducing the spread of resistance and managing things more effectively. So with the last two slides, this message here I want to take you to take away with you is this thing called cross resistance. And what I mean by that is that there's some antiseptics out there that we're finding now actually work on the same genes that are involved with antibiotic resistance. So the longer you keep using certain antiseptics, what will happen is these will start switching on antibiotic resistant genes and you start selecting for antibiotic resistant isolates. So this can start promoting antibiotic resistant populations. And this is generally very prevalent when we're using sublethal, subtherapeutic levels of antiseptic. So we found these with things like benzalkonium chloride, for example, and triclosan. This is why the FDA and the EU are banning a lot of these antiseptics, particularly in cosmetics and also in soaps, because they're finding, whilst they're in there to preserve those products, they're finding there is a knock-on effect in selecting for resistance to antibiotics. What it comes down to is using these antiseptics appropriately, making sure they're being used in environments that are a lot cleaner and not using them indiscriminately, only as and when they are required. So there's lots of things out there that we can get a hold of now that don't necessarily have this antiseptic potency, and we can find some antiseptics as well naturally produce agents such as superoxides that are things like chloramines, chlorine dioxide, hypochlorites that simulate what white blood cells do. Because some of these antimicrobial formulations as well, it's just not about killing the bugs, but it's also about breaking up slough, breaking up necrotic tissue. So these can start breaking down and cleaning the wound up as well. So using enzymatic systems have been shown to start breaking up the matrix, and these help in the debridement and desloughing and cleaning up of the wound. And if they have the added benefit of these natural superoxide solutions that support the immune system, this can only be beneficial to the healing process and supporting the patient's immune system to healing. So in conclusion, we have to bear in mind that bacteria exposed to sublethal concentrations of antibiotics can actually lead to an enhanced prevalence of selection of those bugs that have resistance. We have to be careful that when we're using antimicrobials as well, they're not used indiscriminately and they're not misused, and they're used when it's a bacterial infection if it's an antibiotic, because of course these won't work on viruses. We know antimicrobial resistance is a growing worldwide problem, and everybody needs to improve education in this area. So greater awareness of the existence of things such as biofilms is very important, because as we know, biofilms are over 1,000 times more tolerant to antimicrobials. Therefore, we have to use higher levels of antimicrobials for a longer period of time. Otherwise, we will constantly get regrowth of these actual biofilms and prolonged chronic conditions. But thank you very much indeed for listening, and have a good evening.
I hope you enjoyed that. I found it absolutely fascinating in terms of, the increase of the knowledge that we've had recently, especially about wounds and biofilms. I found it fascinating just to think about where we've come from over the last decade with all of that. So thanks for that, Steve. If you've got any questions, please add them to the chat boxes. We'll be answering your questions at the end of all of this, when both me and Steve will be back to answer those. So I just want to bring it really, now you've been introduced to the concept of biofilm and the importance of antimicrobial stewardship in the area of wound management, I just want to really bring it back now in terms of wound healing. When we think about wound healing, I love this reference in terms of definition, because the process of wound healing is a dynamic, natural, efficient process that involves the overlapping of various healing stages with a continual sequence of regulatory mechanisms to bring about that ultimate wound healing. And even though that definition is relatively old now, I love it because it really starts to bring home actually the complexity of this. And I think many of us actually look at a wound and expect a wound to heal. But actually, I'd like you to change your position on that and really think about, where could this wound start to fail? Because the complexity of wound healing requires this exact science of regulation, moving through that hemostasis phase to that inflammatory stage, that proliferation stage, and finally to that maturation stage or remodeling. And we need the right amount of growth factors, cytokines, enzymes to be able to manage that wound. And actually, if you get an increase in amount of bacterial burden throughout any of those stages, wound healing will start to be impacted. So when we talk about wound healing, this is what we truly mean. You can see that this patient's got a chronic venous leg ulceration. You can see on that first image, it's stuck in that chronic inflammatory stage. You can tell that by the fragile granulation tissue, that beefy red tissue that looks slightly milky, that if you touch it, it would probably start to bleed. That wound is highly likely to have a biofilm present on it. And the reason why that wound's not been allowed to heal is the fact that this is a patient with a venous leg ulcer who wasn't being treated with adequate compression. As soon as you start to manage the wound bed effectively, along with applying strong compression therapy, you start to change that wound bed, reducing that chronic inflammation, allowing it to start to granulate, move through that proliferation stage, which involves the granulation, the bigging up of the tissue void, along with that epithelialization, the skating over of those skin cells. So you get that complete tissue covering. And even though the wound to me and you may look healed, we have to remember that up to a year after that complete epithelialization has occurred, there's an aspect of remodeling. Those tissue planes, those that start to remodel. So we bring back that full function of that skin in terms of the tensile strength, the ability for sensation to control temperature. And all of this can take a long period of time. I found it fascinating that actually when we start to think about what is the cellular difference between an acute wound or a chronic wound, or a wound that is healing compared to a wound that's not healing, there's only really two big differences. The number one is the increased amount of MMPs in terms of chronic inflammation, and the other one is simply the presence of a biofilm. When it comes to wound, the best thing I've ever taught myself or read about was actually the time method of wound assessment. And I just want to remind you the beautiful aspect of using this as a way for wound assessment, because that simple 4-letter acronym starts to provide a really systematic approach to wound assessment. It gives you a structure, a methodical order, so therefore we can get that coherent and consistent outcome in terms of what is our wound assessment. And that 4-letter acronym simply stands for tissue, asking yourself, is the tissue viable or non-viable? Is there any evidence of infection or inflammation? What's the moisture level like? And what's the wound edges? Are they advancing or healing, or are they finding signs of undermining or chronic steep cliff edges? So I just want to take you through each of these aspects in turn. So if you simply ask yourself the T in time, is the tissue viable or non-viable? You start to really think about, basically, do I need to debride the wound or not? You can see that there is some types of devitalized tissue on this slide. That necrotic tissue or eschar is a barrier to wound healing, as Steve has already said. That fluffy tissue that's there is going to be another barrier to wound healing and will harbour a biofilm within it. So both of those pictures, you're going to want to debride that wound. Whereas that healthy, beefy granulation bed actually doesn't require debridement. It simply requires good nurturing with no trauma on that wound bed to allow that wound to continue to heal. And we know debridement is really useful in wound care because it starts to remove that physical barrier, that physical barrier that's not allowing that epithelialization, that granulation or that epithelialization. We've also know that it harbours a significant amount of bioburden within it. So what we want you to think about really is if you've got a wound with devitalized tissue with necrosis or slough, I want you to start thinking of that in a negative way. That's in a minus position, if you like, in your journey to wound healing. We need to remove that barrier, remove that devitalized tissue, and only when we get to that point, then we can start to actually move that wound towards that wound healing. So the simple T in time says, is there any evidence of infection or is there any evidence of devitalized tissue? Is the tissue viable or non-viable? The next question comes in terms of that infection or inflammation. And I think that we need to be really careful of how we use the word infection, as it is directly linked to the use of antibiotics. We have to remember that an infection is the microbial growth and multiplication that leads to that invasion of the host, but also it triggers that host response, that immunological reaction. And you can see that we have pictures of different types of infection within this. In terms of that top picture is classic cellulitis, in terms of systemic infection, and that bottom picture is Pseudomonas in terms of localized infection. And we would treat those very differently. One may be treated with a topical antimicrobials, whereas cellulitis will require some form of oral antibiotics. The IWII looked at the presence of bacteria within wounds, and I love this diagram because it really starts for us to understand that actually there is a continuum in terms of bacterial burden, but actually biofilm is going to be present in most of these wounds that we're talking about. So your ability as a clinician to be able to recognise biofilm is really important. When we say recognise biofilm, biofilm cannot be seen with a naked eye, but the consequence of an unmanaged biofilm can be seen within a wound. The first thing that happens is that you will get delayed wound healing. You tend to find that you get this sluffy tissue that easily reforms with a gel-like covering that you can actually easily sometimes just pull away from the wound. It's rapidly reforming slough or Pseudomonas colonization that you simply just can't get on top of. That's because of the presence of biofilm. And all of this chronic wound state will reduce the ability of that wound to heal, increasing the amount of exudate, increasing the amount of chronic inflammation. And we will have this low level, constant, persistent inflammatory state, which is just not allowing that wound to heal. So the first T in time is thinking about the tissue. The I in time is thinking about that bacterial burden. The M in time then starts us to think about what's the level of moisture. And I think wound exudate has got a relatively bad name. We have to remember that wound exudate is there and required in all the stages of wound healing. It really helps us to get that wound to start to auto-debride, to get that wound moving through those stages of wound healing. But the difficulty becomes is when that wound gets stuck in that chronic inflammatory stage, you can have an increased amount of exudate levels, leading to increased amount of cytokines, proteases, and all of this starts to impact on the growth factors themselves. So what we want with moisture is actually we want a wound bed which is an optimal condition, one that has got a moist wound bed to enhance that autolytic debridement process, to allow those epithelialization cells to be able to skate over the top of it. And we want one that really starts to think about enhancing that wound healing, because within the exudate, it does contain all the protease, the cytokines, the building blocks, if you like, to allow that wound to start to heal. And then finally, the E in time simply asks you to start to think about, is the wound edge showing signs of healing? So that top pressure ulcer that you can see them undermining of that wound bed. And that's simply because you haven't eliminated the underlying cause. You have that patient still actually on their bum. Those bottom two wounds, one's a basal cell carcinoma and one's a squamous cell carcinoma. And the reason why those wound edges are not proliferating is the fact that we haven't identified the correct diagnosis. So actually, it has to start, if your wounds are not decreasing in size, questioning, have you got the correct diagnosis? Then you need to think about, have you managed your wound bed appropriately and prepared that wound bed for healing? Have you debrided? Have you controlled the infection and the biofilm? Have you got the optimum levels of moisture? If you're getting all of that correct, it's at that time you need to be thinking about using cellular products to be able to actually proliferate that wound bed healing further. And I think the true benefit of time is it starts us to think about, what's the aim of my wound care at this moment in time? What am I trying to do? Am I trying to debride the wound? Am I trying to control the infection? Am I trying to control the moisture? And this really helps us as clinicians to think about, which is the product that I need right here and now. Because I really understand the complexities of choosing the right dressings. At this moment in time, there's around 850 wound care products available within the NHS within the UK. And how are clinicians supposed to choose the right one out of that huge amount of choice? I get that sometimes it's based on evidence, or should be. There should be some clinical guidelines in terms of how is it helping us to decide what we're doing. But actually, often it comes down to what's physically available, what's in that shelf in that clinic, what's in the boot of my car, what's in that patient's home. And we really need to be thinking about having products that don't just pick one aspect of time, that products, though, that could be used throughout the whole spectrum of wound healing. And I just want to touch on a little bit about antimicrobial stewardship. I know that Steve's already talked about this a lot. But antimicrobial stewardship within the NHS is out there all in every policy that you read. We have antimicrobial stewardship guardians, we have audits, and we have to actually do reports to think about how we are using antibiotics in a more careful and meaningful way. But actually, I just want you to think about, what, in terms of wound care, do you see this organisational healthcare system-wide approach to actually monitoring the use of antibiotics to be able to preserve their effectiveness? Because sometimes I think it's a bit like, where's Wally? I'm not too sure I can see it. I think we know from many of the studies that actually, if you have a chronic wound, you're highly likely to get oral antibiotics. Of all wounds that's out there, acute and chronic, half of those patients have had at least one course of antibiotics prescribed to them. It's a real prevalent area of use of antibiotics. And I think the reason for this is actually wound care is not owned by one specific specialist. There are many people that could see a patient with a wound, and therefore there can be judgment that's made that sometimes is in error. So both of these patients that you can see on this slide were treated with antibiotics for infection, and both of these patients did not have signs of clinical infection. They just had poorly managed wound care with maceration in both cases. So actually, when I think about good antimicrobial stewardship, I think it's about us having the ability to recognise infection. It's about us knowing about our local infection treatments and also those systemic infection options, and being able to distinguish between a local infection and systemic infection. I urge you all to be part of your wider MDT. I couldn't work within my service without my consultant microbiologist being there to help me with the most difficult of cases. And also, I urge you to really read your local policies, because many organisations will have specific algorithms for things like diabetic foot infection, whether that's localised infection or whether that's deep infection. And all of these can really help us to understand the role of antibiotics and use these responsibly. But it comes back to exactly what Steve said. Prevention is better than all of this. And this is really where Flaminil comes in. This webinar this evening is sponsored by Flen Health, but I use Flaminil every day in my clinical practice. And I do this because it's extremely unique. It's unique in its category. There's no other product that's available like it. It has a naturally occurring antimicrobial protection within it. So therefore, it can really help to prevent that biofilm from forming and that infection. It's extremely versatile. It can be used to debride, to control the infection, to manage the moisture levels, and to protect that wound edge. And it's extremely easy to use. It comes in simple 2 formulas, and depending on the level of exudate, you choose the hydro if you've got a slight to moderate exuding wound, and you choose the forte for higher exudating wounds because it has a more content in terms of alginate. But I just wanted to touch on this difficult to dress areas, if you like, because I don't think many of you will be seeing nice little leg ulcers like that, where you can easily put a dressing on, easily put their compression on, and that's a relatively easy dressing change. But I don't think your wounds out there, especially in community practice, are as easy as this. I say this because I think that you're dealing with a number of different variations of wounds. The first one I want to talk about is the void. We know that actually if you put a dressing on a wound and you haven't got direct contact to that wound bed, you're going to increase the amount of bacterial growth. So we need to make sure that the wound products that we're choosing really combats that base of that wound. If you see all of these pictures, none of these wounds are relatively flat. They've all got crevices in different areas. If you think about the products that you've got available to you, how many of those will ensure that you've got complete elimination of that void? I also think we need to concentrate on that wound edge. We know that this is where the biofilm lives. Each one of these wounds have got these steep cliff edges. These wounds are non-advancing, they are not improving. And that's highly likely because the biofilm is underneath that edge, if you like. So how are you going to ensure that the product you're choosing actually lays inside that wound and touches that wound edge? Some of the products that we use, we need a 1 centimetre margin across that wound. So they're not going to have direct contact with that wound edge. But also, if you're thinking about, we're trying to actually save money within the healthcare systems. So if you've chosen a product that's aimed to debride this pressure ulcer that you can see, and the debridement starts to happen, well, you need to move away from your debridement choice dressing to another dressing. And therefore, this product choice, is this 2 prescriptions, 2 boxes in the patient's home, is that a waste of product? Choosing something like Flaminol that can be used throughout that debridement process, or even to protect that healthy granulation tissue, helps to think about reducing cost. We also need to think about when we've got mixed tissue. So within that wound, you need to debride some of that fluffy tissue, but protect those healthy tendons. Within that other wound, you need to be thinking about, okay, I've got a wound with a black area that I want to debride, that devitalized tissue. I've got a cavity in the middle. You don't want to be choosing different dressings for different locations. There's a high degree of error of how you're going to communicate that to your members of staff. Put X dressing on the black and put Y dressing on the red stuff. Well, what happens when the black starts to debride and goes red? What should they do now? Choosing one product that can go over all of this mixed tissue type can really start to simplify wound care. And then what if you've got a sinus like this? What type of product are you going to be able to put in that sinus to ensure you've got complete coverage of that sinus, but you're not at risk of retained product? Again, using Flaminol gives you that opportunity. And if you've got wounds in challenging locations such as groins, you're going to have a challenge of how you're going to put on that secondary dressing. So choose a primary wound dressing that's going to be relatively easy to apply, and then we can concentrate on actually, do we need to use adhesive dressings, or can we bandage these areas? Or do we need to use some form of net elastic dressings to be able to actually keep that wound, that secondary dressing exactly where we need it? And if you think about wounds that's healing and proliferating really well, the important thing with this case is to manage that biofilm. Because if that biofilm is allowed to proliferate, that wound healing will stop. So we need to be choosing a product that can lay down within that cavity, but also is going to protect from that microbial burden. And again, we need to think about those challenging locations. I'm a vascular nurse, so feet is where I work. But what type of product can you do, especially if you're working single-handedly? What type of product can you do that's balancing on that heel whilst you apply that secondary dressing? The versatility of the the versatility of the Flaminol is you can apply it on that secondary dressing, and then you can just hold it on to that heel to allow that single-handed dressing change to take place. And if you've got wounds like these are some of the most challenging wounds I think that there are to dress, because actually we need products in between all of that individual space. But actually, if you're going to use something like a hydrofiber, are you going to weave all of that product in between all of those tissues? How are you going to make sure that you're actually getting contact with that wound bed itself, right up to that wound edge? These can be very challenging. But actually, the use of Flaminol in these cases can make it relatively simple. We don't have to worry about it touching the healthy skin. We can simply apply it on these cases, and we get results such as this after only 1 week of application. And you can see the significant difference that this has made in terms of helping to eliminate that devitalized tissue. And it's the same as when we look at cavity wounds. If you look at this diabetic foot amputation, you might not think that that wound has much of a cavity. It looks relatively superficial until you get your wound probe in there, and you're going down to 2 centimetres in one direction and nearly 3 centimetres in the other. We need to be ensuring that we've got product right down to the base of that amputation site to help prevent further infection and the risk of ongoing osteomyelitis. The use of the nozzle on the Flaminol helps you to get right down to the base of that tissue to be able to apply it, and then we can simply shape our secondary dressings to have a beautiful contour to that foot. And we need to think about the evolution of these wound products. Many of you may have been in wound care for many years. We have to move away from these dressings that just simply change the environment. These were born in the 1990s. Nothing from the 1990s is up to date. We need to be thinking about using the more interactive dressings, the dressings that's actually going to help us to prevent infection and modulate that wound bed towards healing. Because if you think about that, the only difference between the acute and the chronic wounds is that chronic inflammatory state along with that biofilm. Products like Flaminol helps us to solve all of those issues, moving that wound from that acute, that chronic state into that healing state. And the reason why I support Flaminol so much is I think that we have faced with a significant challenge within the NHS. The workforce is changing significantly. Just look at some of these titles within my own organisation. How are we supposed to educate the whole of this workforce to be able to understand the complexities of wound healing? Maybe we don't need to educate everybody about the complexity of wound healing. Maybe we need to start to think and simplify things, choosing one product that covers all those aspects of that tissue, infection, moisture, and wound edge. Maybe limiting choice helps to increase the availability of that product in every setting within healthcare. Maybe it helps to increase the knowledge of that product by that individual, and it aids that consistency of care. Let's not swap and change between wound products. Let's stick with one wound product and think about actually the underlying pathophysiology and the known evidence-based treatments for that. If we start to concentrate on that bigger picture, then actually maybe we start to move things through that healing cascade sooner. Because actually, as much as this progression to healing was because Flaminol was applied to the wound bed, it was mostly because evidence-based practice in terms of strong compression therapy for venous hypertension was applied simultaneously. We need to think about that pathophysiology, the evidence-based treatment, but then focusing on that simplicity of wound bed preparation. Thank you so much for listening. I hope you've enjoyed that session. And I'm just going to very quickly now try to find my questions. And at the same time, hopefully, we have Steve back in the room with me. Hi, Steve.
Hi there. Fantastic.
So we've had a few questions whilst we've both been chatting, if you like. And we've had an interesting one about the presence of biofilm on acute wounds. So can an acute wound have a biofilm? And is there any difference between normal acute wounds and actually acute burns?
Yeah, there's a lot more evidence is growing now that we do find biofilms in acute wounds. many, many years ago, Professor Peter Kennedy from Australia found a lot of biofilms on burns patients, whereby a lot of their wounds weren't healing. And even now, we're finding a lot of incidents, particularly with surgical site infections, that there are biofilms on those wounds as well. And we've got to bear in mind, particularly in an acute wound, you're going to find a more active biofilm. And what I mean by that, there's a lot more activity taking place, probably less slow growing cells like you'd find in a chronic wound situation. So the way to manage them can be different. Of course, with an acute wound biofilm, these are going to respond a bit quicker to antimicrobial interventions because they haven't settled in, for want of a better term, as much as a chronic wound. Because within a chronic wound, if you've got a biofilm in there, which you will do, it becomes part of the normal microbiology, for want of a better term. So it becomes harder to remove them because they've had a longer time to establish and develop into a multicellular, and they often call it, you've got an alien inside. You have an independent microbial population that can withstand any outside perturbation. So you can change the pH, change the whole ecosystem outside of a biofilm, but inside it will remain in a hemostatic state. So that's going to be slightly different in a chronic wound as it will be in an acute wound situation.
And then we've had another question in terms of odour from bacteria, if you like, asking if Flaminol would be effective in malodorous wounds. Have you got any comments on that, Steve?
Well, when you do get a lot of malodor, of course, years ago there was always a sniffer sort of device that was being developed, wasn't it? Of course, and there's lots of work taking place on smells. And bugs, of course, have this, they're called alarmones. It's called the smell of death. So we can actually use that as a good correlation to see how effective you're killing microbes, of course. So anything generally that is reducing the numbers of microbes, and in particular reducing anaerobes, because it's generally the anaerobes that are producing more of the smells. So you just think about when you have a infection in the tooth. Generally, if you've got an abscess, you're going to need your metronidazole because you're dealing with anaerobic bugs, and those are the ones that produce the smells. So any form of antimicrobial, any sort of debridement mechanism, if you can reduce the microbial population, you will reduce the odor issues significantly.
And for me, it really depends on where's the odour coming from, if you like. So there is a specific smell that you get with osteomyelitis. Flaminol's not going to be effective on osteomyelitis. It's not going to get there. There's a specific smell that comes from very significant burdens of necrotic tissue. And the Flaminol's going to help that debride, but actually the best thing to do is surgical or scalp sharp debridement of that. But in terms of normal wound odour, let's say, Flaminol can be really highly effective because it helps to just to bed down that bacterial response that's causing that wound odour. So I suppose it goes back to really understanding the pathophysiology of where's the odour coming from. There's a quick question in there for me saying, what wick would you use with Flaminol? The beauty of Flaminol is you don't need a wick. So there's a great study that's going on at the moment about packing versus non-packing, especially in pineal sinuses. We're finding actually that you don't need to pack a wound to aid it to heal. And actually, the beauty of the Flaminol is you can just simply put it into any sinus without any form of wick and it'll do its job. It really reduces the chances of retained wound product, which is becoming more and more of an issue in the NHS, especially in terms of litigations. So there's another interesting one for you, Steve. Do biofilms present in closed wounds? I suppose the answer to that is yes, because biofilms can be present on skin. Would you say that's right?
Yeah, and you find that with a lot of wounds that are being closed, so the sutures of them up, and you often get dehiscence. So the thing is, of course, you get bugs growing underneath any of the incisions, and even though they close them up, you'll get them also on the sutures, of course, growing on there. So particularly the orthopods like using a lot of irrigating solutions as such to help reduce that microbial load that may have developed even on sutures.
And then there's another one saying, are there any wounds where you would not advise debridement of necrotic crusts? It comes back to, again, before you're going to start to debride any wound, before you're going to start to choose any wound product, you've got to have done that holistic assessment, identifying your underlying pathophysiology. if there is a suspicious of arterial insufficiency and arterial wounds, you shouldn't go ahead and debride that wound by any form or whatever product, because what we don't want to do is to remove that relatively protective necrotic cap until we've got good blood supply, because we've got a huge risk of actually making that wound bed bigger, exposing that sloughy tissue underneath, and more chance of getting spreading infection. So with any wound, you should never start debride until you understand the pathophysiology. With an arterial wound, never start to debride until revascularization has taken place, or on the advice of specialist vascular teams. So there's a question as well that following on from the sinus one, with a question, does that mean that the flaminal doesn't have to be removed from the sinus? You can remove it, and I tend to wash it out with just some saline. But however, there is no specific need to remove it. If you leave any of the flaminal in, it's a naturally occurring product. It'll just break down in terms of an inert product. It'll just break down within the body without any problems whatsoever. So there's another question saying, if you've got quite an extensive large leg ulcer, how would you apply the flaminal? If any of you remember some of the other gel dressings that were really difficult to apply, you were sort of squirting it on and it were like dripping down your leg. And I tend to find that if I'm using like steroid creams, they're half dripping down the leg as I'm trying to apply them. And the good thing about the flaminal, you can simply just squeeze it all onto your secondary dressing and simply apply it to the wound bed itself on the secondary dressing. You don't have to worry about the splat effect, if you like, because it doesn't damage that surrounding skin. So I can see that there are some questions specifically in relation to the effect of flaminal, but I'm going to actually refer those, if that's okay, to Flen Health themselves. So if you've got any specific questions relating to flaminal, or you're wanting some samples, or you're wanting to have further information, please contact them at info@flenhealth.com. So Steve, I'd just like to thank you. I found your knowledge fascinating, and we so need you clever scientists in this world of wound care, if you like, to help us move forward, especially understanding that impact of a biofilm. Because since I've started to have an anti-biofilm strategy within my wound care, I've really found that I've got a significantly less number of chronic wounds. And so thank you for your science and your knowledge. I'd also like to thank
you as well.
I'd like to thank Flen for sponsoring this event, and also to Mold Digital for supporting this. So thank you so much. Any questions we haven't had time to answer, we'll try to answer them directly with you and by another forum. Thank you so much, and enjoy the rest of your evening. Good night.